Good afternoon, everyone. On behalf of Harris Affinity Decision Support, I'd like to thank HFMA for the opportunity to present to you today, and thank you all for your interest in compelling evidence in the case for activity-based costing. We're going to start today with a brief history of Harris Affinity Decision Support. Then, for those of you that may not be as familiar with what is activity-based costing, we'll provide a brief ABC overview and discuss how decision support systems such as the Affinity Decision Support tool is used to provide ABC data to our healthcare partners. We will share with you the results of a comparative analysis that we, in partnership with one of our hospitals, in which traditional charge-based costing methods were compared to the ABC costing methodology. And then finally, I am excited to share 3 case studies that highlight how the ABC data has and is used by our healthcare organizations to improve patient care delivery and reduce costs. So first, a brief history of Harris Affinity. Harris Affinity is a wholly owned subsidiary of Harris Computer. Harris Computer has been providing software solutions for more than 40 years. Harris Healthcare Division is comprised of over 1,000 employees, serving over 7,000 customers across 34 countries. And these numbers actually need to be updated since we recently completed the acquisition of Allscripts Hospitals and Large Physician Practice Business segment, which adds several thousand customers and an additional 4,000 employees to the Harris team. In addition to Harris Affinity and Allscripts, a few of the Harris Healthcare brands that you might be familiar with here in the United States include Pisces Clinical Solutions, Ingenious Med, and Iatrix Systems. Our core products include enterprise clinical and financial software and service solutions. For more than 35 years, our mission has been to deliver data-driven insights that empower healthcare providers to make critical, evidence-informed decisions that optimize care delivery and financial performance. Our name has changed, and our solution has evolved throughout the years, but we have always remained focused on that objective, which is one of the reasons why so many customers, such as those listed on this slide, have been partnered with us for decades. We work with standalone acute and non-acute facilities, as well as multi-site health systems, including hospitals across the province of Ontario. Harris Affinity Decision Support, or ADS, includes modules to manage cost accounting, contract modeling, budgeting, forecasting, as well as reporting and analytics features for meaningful use of the data. However, today, we will be focused on activity-based costing, which is one of the features in the ADS costing module. I'm part of the professional services team, Director of Professional Services with Harris, and I'll be celebrating my 17th year working with ADS this month. For the past 15 of those 17 years, I've been part of the activity-based costing implementation in the province of Ontario. And providing that ABC solutions and services to our Canadian partners is in large part the reason that Harris is recognized as experts in activity-based costing. Canadian hospitals have been doing ABC for decades. As a single-payer health system, charge data required for other costing models besides ABC was simply not available in Canada. So due to data availability, our neighbors to the north are well ahead of U.S. healthcare organizations in adopting ABC. But because ABC is recognized as the better costing method, we are starting to see a shift as U.S. hospitals abandon charge-based methods in favor of the more accurate ABC methodology. As of today, we have implemented ABC in over 90 facilities across the U.S. and Canada. In Ontario, we assist in annually processing $17 billion of ABC cost data to submit to the Ontario Ministry of Health using the ADS solution. And that ABC information is used to inform funding formulas, determine case weights, and align healthcare practice and costs. Now, for those of you that may not be familiar with what is activity-based costing, the next few slides offer a quick overview. While ABC has been gaining popularity in the healthcare industry, it was actually originally first developed for use in the manufacturing industry. The method was developed to determine the cost of each product and service based on resource consumption of those products and services, and to allocate direct and indirect cost based on that resource intensity. In healthcare, ABC is globally recognized as the most accurate approach for calculating costs. Similar to its predecessor in manufacturing, activity-based costing in healthcare assigns cost to each supply and service based on the resource intensity, then aggregates that cost to create a patient-level cost based on the supplies and services consumed at the individual patient level during their stay or visit. The ABC approach is used internationally in public as well as private healthcare systems. In Canada, ABC has been used for over 30 years to provide comprehensive data to formulate Canadian healthcare funding. The data is used both nationally and provincially for healthcare funding formula, evidence-based policy decisions, and patient care management. Now, in the U.S., most healthcare organizations who have been using decision support data to help make informed decisions calculate their patient costs based on a ratio of cost to charge, or the RCC methodology, as it is commonly referred to. Now, this approach has been historically successful, mainly because healthcare has been profitable. However, perhaps now more than ever, healthcare organizations are facing intense pressures to reduce cost while at the same time maintaining or improving wait times, volumes, and outcomes. And because of these pressures, healthcare organizations need to change their healthcare financial management and strategic planning. So while RCC continues to be the most prevalent approach used in U.S. healthcare, we are starting to see hospitals shift to ABC model because it does offer a more accurate depiction of the utilization and cost drivers. The RCC approach aggregates department-level costs and applies these costs to the patients based on the amount the patient was charged for the services received during their stay or visit. Now, this methodology has several limitations. At the patient level, there is a single cost developed for an activity, such as a knee implant. So cost variation is not appropriately captured from patient to patient using the RCC method. Also, RCC uses broad assumptions to create high-level cost data, but that information does not offer the granularity to fully understand the difference in care delivery from patient to patient and how that impacts cost. In comparison to charge-based costing methods, such as RCC, activity-based costing does capture the details of the patient journey, giving a comprehensive view of the resource and cost drivers. By connecting clinical, operation, and financial data points, ABC provides detailed clinical care data with cost precision needed to inform complex decisions. Activity-based costing is often referred to as a bottom-up approach. The cost of care is calculated at the most granular level by capturing all healthcare services and supplies received by an individual patient during their stay or visit. Because of that, activity-based costing provides greater detail and cost precision than methods such as ratio of cost to charge. The ABC methodology calculates the cost of these services and supplies. That includes the cost of nursing, the drugs, the lab, imaging, OR, therapeutic services, and both direct and indirect costs are distributed to the individual patient. We know that better cost information is critical to our mission to help our healthcare partners optimize the quality of care and improve financial management. And that is why we are so passionate about the adoption of activity-based costing at healthcare organizations. We know the ABC data provides the information needed to effectively budget and manage the complex healthcare services. When used in conjunction with expected reimbursement data, accurate costing data is critical to fully understand the profitability at all levels. Adopting activity-based costing is not difficult. The utilization and clinical data that is necessary for activity-based costing is available in your EHR system today. Combining that data with the financial data from any healthcare finance system is everything you need to calculate ABC costs. Adopting activity-based costing will provide the evidence-based information and cost precision at all levels to compare payer data with activity-based costing so that you better understand not only the cost but as well the profitability and risk throughout your operations. Financial and strategic decisions can no longer be based solely on the RCC assumptions. On average, 65% of healthcare systems that commit to deploying comprehensive, data-driven decision support programs, such as activity-based costing, benefit from higher net operating margins and substantially improve financial and clinical outcomes as compared to those that don't. So at the risk of sounding a little repetitive, it is imperative when choosing a decision support system that it has the capability to do activity-based costing. Our healthcare organizations rely on the ABC data provided from the ADS system to make informed decisions. ADS integrates that patient utilization and clinical data from the EHR systems and the financial data to calculate ABC costs. The patient utilization data includes all services and supplies captured at the individual patient level, and all direct and indirect costs are allocated to those services and supplies based on ABC methodologies. This provides the granularity that our healthcare organizations need to analyze cost drivers and understand variance in patient care and costs. In an effort to continually improve the cost precision and timeliness of the data, we have developed ABC features within the ADS system to provide reliable data to the decision makers on a timely basis. All costs are allocated to the patient level in the ABC model. This includes overhead costs, such as registration and housekeeping, as well as administrative costs, such as nursing admin, lab admin, etc., and the patient care costs, of course. Those overhead, administration, and patient care costs are allocated using ABC methods to create a cost for each service and supply. Those costs are aggregated based on the patient-level utilization to create a patient-level or case cost. So to do that, there are 4 key ABC cost distributions. First, those overhead costs are allocated to the patient care departments that utilize their services. This can be done either using industry standard best practices that have been built into ADS, or it can be based on user-defined inputs. Similarly, the nursing admin costs, lab admin costs, all of the administrative costs are distributed to the patient care departments. Again, that can be based on best practice standards built into ADS or user-defined inputs. The patient care department costs, along with those overhead and admin costs, are then assigned to each service and supply in the patient care department. So we assign the cost for supplies based on the actual or acquisition cost of those supplies, and the costs for the services are allocated based on the time required to provide that service. These service and supply costs utilized by the individual patient are then aggregated to the patient level to create the case cost. ADS is continually designing new features to improve ABC. Working with our healthcare partners, we developed the actual cost feature, which provides even greater supply and drug cost precision. Most recently, we developed and launched the time factor feature, which facilitates accurate labor costing. I've had the opportunity to interact with several of you at our Harris ADS booth, and I've heard from several of you statements such as, we've thought about adopting an advanced cost accounting system, but the time required to implement and maintain the system has always stopped us from moving forward. Actual cost and time factor in ADS greatly reduces implementation and ongoing maintenance time, as these features eliminate the need for complex time and resource studies that have historically been used to create and maintain relative value units, or RVUs. Actual cost and time for the services, supplies, and drugs is readily available in your EHR systems. Using the actual cost feature allows for more precise costing of the drugs and supplies. It does this by using the acquisition cost of the drug or supply as the allocation basis. So that's a fundamental rule of activity-based costing. Unlike RCC and RVU methods, the actual cost feature also manages fluctuation in drug and supply costs throughout the year as vendor supply contracts change. This information is imperative to our hospitals as they use the data to trend drug and supply costs and budget appropriately. The data is also used to compare physician practices and identify opportunities to align care. This leads to an improved patient experience and often also leads to cost reductions. And in just a few slides, I'll be showing how some of our hospitals use their ABC data to do just that, improve patient experience while reducing cost. The time factor feature accurately allocates labor cost by using the time required for each patient activity. This includes the time needed in each nursing unit by the patient, the time required to collect and result all of the lab tests, the time required to administer the patient's imaging exams, the time the patient spent with physical therapist, occupational therapist, speech therapist, as well as the time that the pharmacist needed to dispense the medication to the patient. And for even better cost precision, patient factors such as acuity or age may be integrated in ADS and then used to weight the time factor. So consider a chest x-ray for a 30-year-old versus a 2-year-old, where the 30-year-old requires one imaging technician and the 2-year-old requires an additional nurse and sedation. Healthcare organizations use this labor cost data to forecast their labor needs. We had an opportunity to present on labor shortage and cost at an HFMA-hosted session in April. During that session, we heard how the current labor shortage was generating challenging questions and how the labor cost data is used within healthcare organizations to help answer those questions. We do have a recording of that session available, so if you were unable to attend and have any interest, please see me or one of the other Harris representatives that are present here today after this presentation. We'll make sure you have access to that recording. When the labor cost and supply cost are combined to create a total cost of care, that total cost of care can be compared to payment data that's also brought into ADS, and healthcare organizations are able to gain a better understanding of profitability at all levels, including by payer, service line, site, and physician. Now, we've been implementing activity-based costing across US and Canadian facilities for years. But until recently, we have only been able to theorize that the ABC methodology is more accurate than charge-based costing assumptions and RVU averages. We were given a unique opportunity to definitively answer that question when one of our hospitals, who has been doing charge-based costing for years, decided to switch to ABC. And they overlapped the two methods for a time period in order to facilitate a comparison. Though we theorized that ABC was the more accurate method, we took a completely unbiased approach when we conducted this comparison with the hospital. The results did not disappoint us. We found that the ABC costs were more accurate and precise based on every measure. ABC provided greater granularity and therefore greater insight into the cost drivers as well as cost and care variation. The ABC method matched to acquisition costs. That's something that the previous charge-based costing methodology did not do very well. Also, the ABC method provided greater labor cost accuracy by using time as an allocation instead of charge data. So we're going to spend the next several slides getting into a little bit more of the detail of that cost comparison. To assess the supply costs of the two different methodologies, we aggregated supply cost at the DRG group level. Whoa. All right. The presentation wanted me to be done. I'm sorry. Okay, here we go. I didn't touch anything. No. All right, so again, to compare the supply cost results of the two different methodologies, what we did was we aggregated supply costs at the DRG group level. We then compared both the ABC supply cost results and the charge-based supply cost results to acquisition costs that we brought into ADS, and we looked at the variance between the two methodologies. The ABC supply cost results were within 1% of the acquisition cost for every DRG group. The charge-based supply cost varied by more than 50% of the acquisition cost for some of the DRG groups. This was largely due to the fact that ABC could accurately assign $12 million of implant costs to the specific patients that use those supplies. The charge-based method that used charges as the allocation methodology was only able to allocate $7 million based on that ratio of cost to charge. And as per the charge-based methodology, that difference in what they could not allocate to the individual patient, that had $5 million variance, was equally allocated to all patients. And what that means is we're looking at undercosting the patients that use those high-dollar implants, and in addition to that, we're overcosting all of the patients that don't use those high-dollar implants. Similarly, ABC accurately costed $24 million of drugs to the specific patients. The charge-based method only allocated $19 million of drugs. If we look at one of the DRGs with one of the highest variances, this one selected that you can see up on the screen is DRG 470, total joint replacement. Now, this report was generated from ADS. It shows us the acquisition costs, which we brought into ADS for the purposes of this comparison, and we used as the allocation basis for ABC methodology. We compare that acquisition cost to the charge-based costing results and the ABC results. So just using that first hip implant as an example, you can see on the screen there the acquisition cost of that hip implant, $2,200 for that implant. When we look at the charge-based results, so using the ratio of cost to charge, the cost for that implant was calculated at $1,225, so almost half of what the true acquisition cost of that implant was, using the RCC method. When we look at the ABC costing method, because it's using the acquisition cost as the allocation method, that discrepancy simply can't happen. Next, we reviewed the charge data and time data to understand why we were seeing labor cost variances between the two different methodologies. ABC costing is based strictly on time. However, we learned when we drilled into the charge data that not only charges based on time were reported against the patient, but also additional charges for activities that did not require any additional hospital resources. Yet, because it is a ratio of cost to charge, those additional activities were receiving labor costs. These additional charges were the root cause of most of the labor variance. Now, this report was also generated in ADS to show the charge-based cost data in one of the departments, the operating room. So you can see on the screen those first two charge codes. We're charging patients for the first hour that they spent in the operating room. We're charging patients for each additional 15 minutes. The remaining charge codes are for activities that the patient was charged for, but they did not require any additional OR resources. Yet, because of the RCC methodology, which accumulates all of the charges at the patient level to do the allocation, those activities were still drawing a cost to the patient. ABC is more accurate because the method is based purely on time. So again, this issue cannot happen with the ABC methodology. Now, one of the highlights of my 17 years of implementing ABC is when I get to see our hospitals using that ABC data to make informed decisions. So I'm very excited about the next few slides where I'm going to get to share with you 3 case studies that were conducted by 3 different hospitals and how those hospitals used their ABC data to answer challenging questions, improve patient care, and reduce costs. In this first case study, we see how nursing cost data generated using the ABC methodology in the ADS system was used to help the hospital plan for staff shortages. While healthcare labor shortages have been predicted for years, the pandemic exacerbated the issue and exposed weaknesses in the current delivery model. The goal of this case study was to understand the volume of services provided by the hospital and compare that to the labor required to provide the care. That information would be used to help inform which services would be most beneficial to transition to virtual care or to other care providers in the area, thus alleviating the pressures caused by the labor shortage at this hospital. The result from ADS provided that comparison. Transitioning patients in services with a low volume to labor ratio would obviously provide the most labor alleviation while impacting the smallest number of patients. For this hospital, the ABC data from ADS clearly shows that the mental disorder, nervous system, and immunological patients were the best candidates for transition. In this second case study, we're going to see how another hospital used their ABC data for hip fracture patients to align patient care, which led to a cost reduction. So a quote that we lovingly stole from this hospital when they presented their findings to us was that the ABC data is used for continually researching cost efficiency and updating clinical best practices through the analysis of their decision support data. The hospital formed a cross-functional team which included members from their decision support teams and finance team, and they included clinicians that were involved in providing care to the hip fracture patients. Using the ABC data generated from the ADS system, they analyzed the clinical pathways of the patients and compared utilization across the physicians in order to align the care and determine a clinical best practice for these patients. As a result, they were able to quickly implement clinical practice improvements within the lab, operating room, pharmacy, and imaging, which also led to cost reductions across those departments. Within the lab, they found that some physicians were ordering multiple CBC tests per day, while others were ordering only one. The clinicians agreed that the multiple CBCs did not provide any useful information for patient care and treating those patients, so the clinical best practice became to order one CBC on day 2 post-op. This led to an annual savings of $100,000 for hip fracture patients alone. The team also discovered that some physicians favored an injectable anticoagulant, while other physicians preferred the oral anticoagulant. While the cost difference was minor for the two different types of drugs, there was no evidence that one or the other yielded better patient outcomes. So they saved the patient from one additional stick in the arm by adopting the oral anticoagulant as clinical best practice, which did lead to a modest savings of $5,000 annually of drug cost. Looking at the detailed medical imaging utilization, there was also a discrepancy in the type of X-ray ordered for the hip fracture patients. The clinicians determined that typically the 2-view X-ray did not provide any insight that could not be gained by using a 1-view X-ray. The clinical best practice was then adopted to start with a 1-view X-ray and determine if, in rare circumstances, the more expensive 2-view X-ray would be needed. This resulted in an additional imaging cost reduction of 25% at the facility. A length of stay comparison was also conducted, and the LOS was compared to readmission rates. Does a longer LOS for our hip fracture patients necessarily reduce the chances that they will be readmitted to our hospital? The answer was no, and as a result, the average LOS of hip fracture patients was reduced by 1 to 2 days. That obviously reduced the overall nursing cost of the case. It freed up the bed that much sooner, and it allowed the patient to start recovering at home. After implementing these clinical best practices, the hip fracture cost was reduced by 11% annually, which based on this hospital's annual hip fracture volume is over $700,000 a year. More importantly, it led to an improved patient experience. The reduction in lab tests and the change from an injectable to an oral medication meant less sticks in the arm for the patient, also reduced the LOS, which means the patient could go home sooner. Our last case study is another interesting one. Using the ABC data, this hospital noticed that the lab cost trend over time had greatly outpaced other cost drivers. So they formed a team, which included decision support analysts and physicians, to identify why lab costs had risen so quickly. Using the lab utilization and ABC cost data derived from the ADS system, they were able to quickly identify the root cause. A digital order set system had recently been implemented, and it included predefined lab orders that were completely unnecessary. This was most evident in ER cases that were admitted to the hospital. It was found that lab tests were automatically being ordered for those patients when they were admitted, even though those exact same lab tests had recently been performed in the ER. After identifying the root cause, the digital order set system was updated to discontinue the duplicate lab testing. The hospital quickly saw a reduction in lab test costs by 14%. And because the duplication of tests was eliminated again, that meant a better patient experience. Based on these case studies and the comparative analysis, we know that activity-based costing provides the most complete, accurate, and precise decision support data that is needed to effectively manage all of the challenges of healthcare operations. ABC data offers the most complete and granular level of information by bringing in all services and supplies utilized by the patient. This offers a level of granularity that is not available in other methodologies, and it facilitates the detailed reporting needed to perform comprehensive analysis to align care and costs. The ABC method is the most accurate. The total cost reconciled to the general ledger, and the cost audits validate integrity of those results. This provides the highest degree of confidence to the decision makers using the data. They can trust that they are basing their decisions on the most accurate information available. The ABC methodology also offers the highest degree of precision by capturing fluctuation in cost from patient to patient and day to day, which allows for improved cost trend analysis. The overall result of implementing activity-based costing at your facility is that decision support information will be available to the key decision makers on a timely basis, and that information can be trusted to make evidence-based decisions regarding the challenging questions faced by every healthcare organization. As well, we've seen that using the ABC data to align clinical practice results in improved patient experience as well as a reduction in overall costs. On behalf of Harris Affinity Decision Support, thank you all again for your attendance to this session. I'm happy to take any questions you have at this time. Also, knowing that the booths are closed upstairs, wanted to finish a little bit early, which I think we will be able to do. So we have an opportunity to meet with you. We've got Brian, Jay, and Will. If you guys can just wave really quickly. If you have any questions, you'd like to talk with us one-on-one, you can find one of these folks from Harris, or you can find myself after the session. Be happy to talk to you more. So with that, if there are any questions, be happy to take them. Sure.
What do you find in terms of the amount of overhead that gets kind of passed into the process, and does that like end up? Oh, there we go. The amount of overhead in some of your hospitals, how does that affect kind of ultimately the ABC costs and people believing, I'll say, in the number versus it being kind of mostly allocated?
Yeah, no, that's a good question. So our indirect or overhead costs range anywhere between 10% to 40% of the overall operating costs within our hospitals. So what we do to help facilities provide data to the end user is we keep those costs separated, so that the cost provided, let's say, to the lab managers, the imaging manager, to the nursing manager, to those users of the data who know very well what their general ledger bottom line operating expenses are, we can remove that from the picture so that they have better trust in the data and see the operating expenses that they feel they have a better control over. Great question. Another question.
How long does it typically take to implement the methodology?
That's another good question, and it really depends if a hospital has already adopted a costing methodology and is pulling data from the EHR system. They've got financial data, all of that. It's adding a couple of fields to adopt activity-based costing, mainly adding the acquisition cost for your drugs and supplies, adding time for all of those other types of services into the information that's already being fed into your decision support or your costing solution. It all depends on how fast the IT resources can turn something like that around, probably a couple of weeks to start pulling that data. Now, for new implementations, we plan, if you haven't done any case costing at all at your organization, we plan for about 6 months. That includes around 6 weeks for IT to start making the necessary data extracts available out of EHR and the financial extracts. It's kind of a one-time heavy lift for IT teams. So around 6 months for an implementation. Yeah. Yeah.
Is this on? Okay, cool. This makes a whole lot of sense. I love what you've walked through from a clinical ops perspective. Have you explored applying the ABC method towards RCM ops in terms of kind of breaking down the different functions of RCM on an activity-based costing method?
I'm looking to the rest of the hair. I don't think we have not at this point. Yeah.
I'll follow up. Maybe it's something
Okay,
I'd like to
great.
explore it where
Yeah.
we're at. Thanks.
Any other questions? Those are great. Thank you. I think that's it. Thank you very much. Appreciate it.
Please remember to complete the session evaluation at your earliest convenience. Evaluations may be accessed through the conference mobile app within each session. Visit our sponsors and exhibitors to thank them for the support. The checkout code for this session is TCAFZ. Again, TCAFZ. Thank you.